This is the story of a girl who cried a river. No, that's a song. This is the Puscast, a review of the infectious disease literature. This is covering the first 2 weeks of February in the year 2018. References are available at edgydoc.com, as well as links to my growing multimedia empire. I'm feeling a wee bit bitter and surly today. I calculated I do about 450, and that's a minimum, hours a year putting together my multimedia infectious disease empire. And you know how much CME I get for it? Nothing. You know how many credits the ABIM says I get to have towards my MOC? Zip. I think I probably do more continuing medical education that's documented and for the benefit of others than anybody on the goddamn planet, and I don't get zip for it. Well, I do have the satisfaction of a job well done, and I always learn something. So, enough of my whinging. Let's get on to the literature, shall we? Most people get hantavirus by being exposed to wild mice, especially in the Four Corners area, but there are hantaviri all over the world, including the Seoul virus, Seoul as in Seoul, Korea, Seoul. This family ran a rattery, which I didn't know was the term for a rat breeding facility, where they had 100 Norwegian rats. And 2 of the members of the family came down with hantavirus, specifically the Seoul virus. And not only do rats in ratteries contain this virus, so do wild Norway rats. As the Medscape article that followed the CDC report states, people with pet rats should practice safe rodent handling and good hand hygiene to avoid catching a virus that can jump from rats to humans. Safe rat handling. How about don't have rats? But add hantaviri to the list of infections that patients can acquire from having domesticated rodents. One of those weird-ass presentations, young man presents with abdominal pain, has an appendicitis, has it removed, doesn't get better, and after quite a workup, they stumble on the fact that he has acute HIV. They go back and look at the appendix, and they find a lot of HIV replication in the lymphoid tissue of the appendix, but nothing that suggests a bacterial infection. So they declare that the appendicitis was due to acute HIV. Sure, why not? The workup this kid got for his febrile illness was remarkable because they didn't consider HIV up front. So while the take-home of this study is ostensibly a study about how appendicitis can be a weird manifestation of primary HIV infection, it's more interesting as a study as to what happens to a patient when the primary diagnosis is not considered for a variety of reasons for the first month or so after admission. Not that I necessarily would have done any better. Medicine's hard. And for whatever reason, herpes is falling. At the turn of the century, that would be 1999 to 2000, 59% of Americans had herpes, as judged by serology. That's now down to 48%. Perhaps in part due to increased condom use, I can only hope. But still, about half of Americans have herpes. And as always, depending on what population you look at, there's more or less than the average, but I can never remember those specifics. A nice bit of viral history in the New England Journal of Medicine. Quote, almost all histories of vaccination state that Edward Jenner became aware of the benefits of cowpox from a conversation with a milkmaid who claimed that she was immune to smallpox because she had the cowpox. End of quote. Turns out that's a myth. Or perhaps we should call it alternative facts or fake news. I suppose if the milkmaid had been married, it would be a mythith. It turns out that, quote, the milkmaid story is a myth invented by Jenner's biographer 13 years after Jenner's death in order to protect his reputation amid the many assertions that he did not discover cowpox. End of quote. The article goes on to demonstrate how it was noted that cowpox was protective against smallpox vaccination. And it's a nice little historical read. But it was a Dr. Fuster who made the first observation that he could not get a reaction to smallpox vaccination in people who had the cowpox. One farmer noting, quote, "I have had the cowpox lately to a violent degree, if that's any odds." The farmer later sold his story to the National Enquirer. There was a study out of the Democratic Republic of Congo, which means it was neither democratic nor a republic, and I say that speaking in the Democratic Republic of the United States. Just kidding, I think. But they found that 11% of people who had never been exposed to Ebola during the outbreaks were seropositive, and it was associated with animal exposures and hunting. But 1 in 10 are seropositive, which is pretty impressive. But also gives you the willies because it suggests that Ebola is circulating a wee bit more than we suspect, at least in the forested villages of northern Democratic Republic of Congo. Regular listeners know my affinity for studies that show a link between infections and various and sundry vascular problems. There has been suggestions in the past that CMV and or EBV is associated with the development of dementia, just like there was a study out of Taiwan that showed that chronic osteo might be associated with an increased risk for dementia. But for every study, there's an equal and opposite study. And this one out of Finland looked at the EBV and CMV serology and cognitive decline in dementia. They found no association. I don't take care of children, so this was news to me. It turns that rotavirus, which causes acute GI symptoms in kids, has also been associated with generalized tonic-clonic afebrile seizures. So, what has happened as a result of widespread use of the rotavirus vaccine? Well, it turns out there's been a decrease in hospitalizations for seizures, suggesting that one of the non-infectious benefits of the rotavirus vaccine is to prevent seizures in children. And I wonder if less dementia. Probably not. The importance of considering every orifice. When checking for chlamydia, that's what happens when gonorrhea and chlamydia merge into one infecting organism. When testing women for chlamydia and gonorrhea, one should also do a rectal as well as genital testing. This study shows that it is not done frequently enough, but interestingly, that almost half of patients with rectal chlamydia and gonorrhea would have not been diagnosed if only genital screening had been done. So we are really missing both the diagnosis and treatment of extragenital chlamydia and gonorrhea. And as long as we're on the topic of sexually transmitted diseases, how about that syphilis? This was an interesting study where 6 patients with early syphilis had PET scans done and their aorta glowed, suggesting that the aorta, like many other places, is involved with early syphilis. I say like other places because there was that old study, 30 years ago in the Annals, that found syphilis in the spinal fluid of people with both primary and secondary syphilis. My take has always been that syphilis is always a disseminated disease, and the classic stages are clinical manifestations of what is always a systematic illness. In all these patients, the PET scans reverted to normal with treatment of their syphilis. I have never seen a case of syphilitic aortitis, and it hasn't been for lack of looking, but I hope I never do see a case, because all the infections I have yet to see are going to be catastrophic for somebody else. See, Canada needs to build a wall too. A very small wall, about, say, 6 inches high. This study looked at the spread of Ixodes scapularis ticks, and they've been spreading up and into Ontario, Canada, probably as a result of climate change. But they estimate that the tick has been spreading north at 46 kilometers a year. That's 28.6 miles a year for us English folk, dragging with it tick-borne illnesses like Lyme disease. I always keep in the back of my mind that the range of infections is changing, and you truly need to expect the unexpected. And you know how much I hate that phrase. And a couple of meta-analyses of note. One looked at the treatment of skin and soft tissue abscesses and found that Bactrim and clindamycin were both associated with a lower risk of treatment failure, a decreased risk of recurrence, a decreased risk of hospitalization, and a decreased risk of late occurrence, but they tended to cause gastrointestinal side effects. Not unsurprisingly, since most of these are due to MRSA, cephalosporins had no efficacy. And this meta-analysis addressed the issue as to what's the best treatment for community-acquired pneumonia. Cephalosporin with a macrolide versus a respiratory quinolone, and they found that the two were the same. In terms of efficacy, although the quinolone group had more side effects. I still think, though, it gets down to what the etiology of your pneumonia is, because around the same time, a study was published in Open Access Infectious Diseases that looked at the etiology of pneumonia in Iceland and found that the gruesome twosome were strep pneumoniae and mycoplasma, and then a lot of the rest were viruses. And has been demonstrated with these recent PCR technologies that the etiology of pneumonia is often a hodgepodge of organisms that land people in the hospital, and occasionally it is multifactorial, with multiple organisms found on the PCR. So the question always is, what is the best treatment for a given organism, not for a given syndrome? And I think the preponderance of data suggests that for treating pneumococcus, that combination therapy is superior. So I think this study kind of misses the mark, or at least it misses this mark. My name, in case you didn't know, is Mark. But since we so often don't know the etiology of pneumonia, it makes understanding as to optimal therapy still problematic. And of course, you know my theory behind a meta-analysis. You take all the piles of bullshit and you put them in one big pile, and you're supposed to get gold, but I think what you often get is just a large pile of bullshit. And as long as we're on the topic of the pneumococcus, there was a study in the Annals that looked at the risk of invasive pneumococcal disease and the use of opiates, and they found indeed there was a risk. The two are associated. Although causality would be interesting, I don't think there's much you can do except make sure all your opiate addicts get the Pneumovax. Of course, you should get them off opiates as well, I suppose. But this study out of Canada in Ontario, where it looks like they're trading pneumococcus for invasion of ticks, looked at the results of the pneumococcal vaccination and found that hospitalizations were down across the board thanks to the use of the pneumococcal vaccine. The new one, the Prevnar, is especially good at preventing invasive disease. So hopefully all the Ontarian addicts are being vaccinated. And finally, when I get a case of pneumococcal bacteremia, I usually work patients up for one of two things. If they're young, I work them up for HIV, and if they're old, I work them up for gamma globulopathies. And I often hit pay dirt with myeloma or MGUS. But this study looked at the prevalence of hypogammaglobulinemia in adults and found that 13% of patients with invasive pneumococcal disease had hypogammaglobulinemia. Although the majority in this study had underlying hematologic malignancies, specifically non-Hodgkin's lymphoma, CLL, no surprise there, and multiple myeloma, which I don't think of as a hypogammaglobulinemia disease, although it actually is, as all those myeloma proteins feedback inhibit real antibody levels. But there were also a hodgepodge of patients with no underlying hematologic malignancy that also had low antibody levels. So it's probably worth checking IgGs, A's, and M's in patients with pneumococcal invasive disease, and probably IgG subtypes as well. A couple podcasts ago, I talked about patients who have a specific anti-carbohydrate antibody lack. So there's all sorts of wonky ways the immune system can go south to increase your risk of invasion from pneumococcus and presumptively other encapsulated organisms as well. I always say that the Borg got it wrong. Resistance is not futile. Resistance is inevitable. The question is what to do about ESBLs. How do you know if it's an ESBL? Well, it's resistant to ceftriaxone, but it is susceptible to cefoxitin, a cefamycin antibiotic. These organisms are often resistant to other oral agents as well, including the quinolones. So what are you going to do for treatment? Well, this study looked at treating prostatitis with cefoxitin, and in the 23 patients that got the cefoxitin, they did quite well, thank you very much, with about an 80% cure rate. The problem, of course, is that's IV. I've been giving a lot of fosfomycin for not my personal, but patients with prostatitis and other complicated UTIs due to ESBLs, and the literature would support its use for a long period of time with equally good efficacy rates. There is fortunately very little resistance to fosfomycin in the United States, although that, of course, will change rapidly once we start using it again. It's amazing how much I know that I don't know, even though I know it. Have you heard of Actinotignum shallii, Actinotignum Well, I guess I have, because there is a page on my app about it, but I've forgotten about it. It's a cause of urinary tract infections in the elderly, and it also is a cause of, in this case report, chronic prostatitis and relapsing epididymitis causing sterile pyuria. It's a slow grower and is often misidentified in urinary tract specimens. This is evidently the third or fourth time I've heard of this organism and completely forgotten about it. Being resistant to quinolones and Bactrim, the best treatment is beta-lactams. But of course, then you have to think of the organism and ask the lab to look for it, which it seems I'm unlikely to do. I keep telling my primary that my CSF VDRL is a false positive. I'm increasingly not so certain that's true. Do you want your stool fresh or do you want it frozen? Well, when it comes to stool transplant, that doesn't appear to make any difference. This meta-analysis found that frozen poo is every bit as good as fresh poo for fecal transplant. Of course, the issue with fecal transplants is you have to have a donor. And once we can use stored frozen poo or poo pills, it'll be a lot easier to give patients the treatment they need. And I've talked about this before, but the meta-analysis supports it. Tetracyclines actually lower your risk for a primary C. difficile infection. So if you have to choose between, say, clindamycin and doxycycline for an infection, maybe doxycycline would be the way to go. Although, unfortunately, because of increased use for MRSA, I think, the cost of doxycycline has skyrocketed of late. And as long as we're on the topic of stool pathogens, here's a bunch of factoids. There was an outbreak of Campylobacter infections associated with raw milk consumption. Not a surprise there. These, however, were quinolone resistant. How did they get exposed to raw milk? Well, the way you get around it is you buy a timeshare and a cow or a goat, and then you can do with that animal whatever you want. In this case, drinking raw milk contaminated with quinolone-resistant Campylobacter. And a couple other stool-related studies. There's an association between severe salmonella and subsequently getting adenocarcinoma of the ascending and transverse colon. Association is not causation, but it's still interesting nonetheless. And there's also an association between eradication of H. pylori and subsequent decrease in the risk of gastric adenocarcinoma. So there's more than just getting rid of the upset stomach and bad breath that come along with H. pylori. You decrease your risk of cancer of the stomach. And also, there's also an association between eradication of H. pylori and subsequent coronary artery disease. I keep saying inflammation is bad. It leads to vascular disease. Coronary artery disease is one of them from your H. pylori. Everything fundamentally is due to infectious diseases. Well, everything interesting. Mycobacterium abscessus is one of those bad rapid growers. I don't think I've actually ever seen a case, but they managed to report 108 patients in Miami. Take home, high mortality rate of those hospitalized, 15.7%. The other take-home is the two most reliable antibiotics were clarithromycin and amikacin at about 94% susceptibility, followed by tigecycline at about 90%, of which were susceptible. And they found that getting a macrolide early on was associated with better outcomes. Otherwise, the organism is pretty much resistant. Same is not quite said of Cryptococcus. How's that for a segue? This looked at the incidence in the published literature of cryptococcal resistance, and it was reasonably high. Of course, it depends on what you think the breakpoints are to determine susceptibility or resistance, but overall they gave resistance rates of around 12%. But more importantly, in relapses, resistance was higher at about 24%. I suspect that it's developing resistance on therapy. It would be interesting to know how dosing schedules of fluconazole affected the development of resistance. I tend to give lots rather than less when I treat cryptococcal disease, especially since I live in Gadii territory, which is harder to treat than the usual neoformans. And another study looked at outcomes of cryptococcal disease and found that HIV patients do better with cryptococcal disease than do non-HIV patients or solid organ transplant patients. The population evaluated in this study were those of cryptococcal disease in California from 2004 to 2010, in Florida from 2006 to 2012, for something over 3,700 patients. Not mentioned in the study were Cryptococcus types, neoformans versus Gadii versus other, nor specific therapies, azole-based versus amphotericin, etc. So you don't know if, say, normal people were treated differently than an HIV patient with their cryptococcal meningitis. So while it's an interesting study, it's a fundamentally unsatisfying one. And how do you treat pneumocystis in non-HIV patients? The study out of Japan found that lower doses, less than 15 milligrams per kilogram per day, had similar efficacy but less side effects when compared to the more traditional dosing of 15 to 20 milligrams per kilogram per day. So they suggest that you can treat your pneumocystis in non-HIV patients with lower doses with similar efficacy and less side effects. More confusing, in the article they call it pneumocystis pneumonia, PCP, but in the CID review of this article, they refer to pneumocystis jirovecii pneumonia as PCP. Shouldn't it be PJP? What does the C stand for in PCP? Does it stand for pneumocystis or pneumocystis carinii? The second P certainly does stand for pneumonia, which is why it drives me nuts when people say PCP pneumonia or PJP pneumonia. Well, please, we need to get some standardization here. In the meantime, you can give your non-AIDS patients a little bit less Bactrim with equal efficacy and decreased toxicities. And it would appear that cystic fibrosis patients can have elevated 1,3-beta-D glucans, but no signs or symptoms of any invasive fungal disease, suggesting it is a group that has a false positive. The other possibility is there's some other organism that's causing the elevated 1,3-beta-D glucan that's not a fungus in the classic sense of the word, since certainly nocardia can lead to an elevated 1,3-beta-D glucan. And another weird risk, the title of the article says it all, primary amoebic meningoencephalitis associated with rafting on an artificial whitewater river. It was a North Carolina water park that was chock-a-block full of Naegleria, and one poor person got meningoencephalitis and died. And I guess that's it, bringing the Puscast to a close for the first 2 weeks of February in the year 2018. References are available at edgy.com, as well as my growing multimedia empire of books and apps and blogs and lions and tigers and bears, oh my. Otherwise, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, goodbye.